Hello, this is Dr. Oviedo. Today I am going to discuss a paper that was published in Lancet on March 12, 2020, which describes the first known person-to-person transmission of SARS-CoV-2, which is the virus that causes COVID-19 in the United States. Here's an image of the first page of the paper. I recommend you read it if you would like more detailed information. This paper, of course, describes the first known person-to-person transmission of COVID-19 in the United States, which occurred in Illinois. Let's start with the summary. Patient 1 was a female in her 60s and lives in Illinois. She traveled to Wuhan on December 25, 2019. In Wuhan, she visited a hospitalized relative regularly. It's unknown if the relative was tested. She returned to Illinois on January 13, 2020, and was not symptomatic while traveling. She was hospitalized 1 week later with pneumonia. She was positive for SARS-CoV-2, which is the virus that causes COVID-19. In the hospital, she wore a face mask in the emergency department. There were droplet precautions in the emergency department, and for 10 hours after that, she was transferred to an airborne infection isolation room. The airborne infection isolation room means that healthcare personnel entering the patient's room are required to adhere to standard contact and airborne precautions, including hand hygiene, gloves, gown, respirator, and eye protection. Patient 2 is the husband of patient 1. He had no travel. He had close contact with his wife while she was coughing. They live together, eat together, and share a bed. He was admitted to the hospital 1 week after his wife with pneumonia. He was positive for SARS-CoV-2, which is the virus that causes COVID-19. In the hospital, he was immediately admitted to an airborne infection isolation room. This paper also describes contacts of these patients. Public health authorities did an intensive investigation of 347 contacts, including both community members and healthcare workers. The healthcare personnel underwent active monitoring. The contacts were stratified into high risk, medium risk, and low risk. I'm going to review this chart from this paper, which describes the symptoms and laboratory studies of these patients. Before we begin, I want to acknowledge the vast numbers of people involved in taking care of these patients and doing these studies. This information is critical to learning more about this disease and is very important in preventing future transmission and for people to learn how to take care of these patients. In this chart, you can see here is patient 1 and here is patient 2. This chart is divided into community, hospital, and home. You can see up here at the top, here is day 0, and here is day 31. These, of course, are the days of investigation. The chart is also divided into symptoms and laboratory studies. Let's take a look at patient 1 up here. You can see this red marks that she had a subjective fever from day 0 up to approximately day 9, which was when she was in the hospital. She also had fatigue. You can see that in orange from here to here. The two symptoms of fever and fatigue are very non-specific. Non-specific means that you can see them in a wide variety of different diseases. Next, the yellow bar from here to here shows that she had a cough. The cough, of course, is more specific to a viral pneumonia, which is, of course, the disease that COVID-19 can cause in its more serious form. In addition, you can see she also has nausea, abdominal comfort, and dizziness as the yellow, light green, and dark green bars down here. Let's take a look at her laboratory studies. These laboratory studies were reverse transcriptase polymerase chain reaction for RNA sequences of the SARS-CoV-2 virus. You can see here that she is positive on day 7 for nasopharyngeal swab, oropharyngeal swab, and sputum. The nasopharyngeal swab is when you take a long cotton tip swab way in the back of someone's nose. You enter through the nostril and go straight back and twist that swab onto the tissue way back in the back of the nose. The oropharyngeal swab is similar, however, in that situation you are entering through the mouth and putting the swab way in the back of the throat. Sputum means a material that is coughed up from the lungs. You can see that her sputum continued to be positive here, 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 and here for multiple days in the hospital, and she also even had one positive sputum over here while she was at home after her admission. Another thing I want to point out is the positive stool here. Some people might wonder, why are they testing her stool? We know she has pneumonia. We know that her sputum and her nasopharyngeal and oropharyngeal swab were positive. We're quite sure of what disease she has. The reason you test the stool is because we are still characterizing how this disease works. It's important to know if the stool is positive because that is a potential route of transmission. Let's go on to her husband, patient 2. He, of course, is also separated into community, hospital, and home. Looking at patient 2's symptoms, you can also see he had a subjective fever here. He also had fatigue here. In addition, you can see he also had cough from here to here. The reason the yellow bar for cough is faded on the left is this patient had chronic obstructive pulmonary disease. Therefore, he always had a chronic cough. So in a patient with chronic cough, of course, it can be more difficult to determine when the onset of this acute episode of COVID-19 began. The most common cause of chronic obstructive pulmonary disease is, of course, cigarette smoking. In addition, a symptom that patient 2 had right here is hemoptysis. Hemoptysis means coughing of blood. It is a very scary symptom, of course. The most likely reason that this patient had hemoptysis while his wife did not is that he has chronic obstructive pulmonary disease and is, of course, much more susceptible to having a more severe form of this type of illness because his lungs have less reserve, meaning they have less of an ability to respond to acute diseases because his lungs are always chronically sick with his chronic obstructive pulmonary disease. Let's go on to summarize the outcomes of these 2 patients. Patient 1 recovered and was discharged to home isolation on day of investigation 23. Patient 2 recovered and was discharged to home isolation on day of investigation 23. Please note that the course of these 2 illnesses of these patients is different. The reason they are both discharged on approximately the same day is because they were probably making preparations to get these patients home. Home isolation was lifted for both patients on day of investigation 33 following 2 sets of negative respiratory specimens collected 24 hours apart. Let's go on to discuss the outcomes of the contacts. There were 372 total contacts for both these patients. 347 of these were actively monitored. Of these, 195 were healthcare personnel and 152 were community members. Some of these contacts, of course, overlap with both of these patients, and some of them are unique to each patient. Please read the paper for more details if you wish to know more about that. 44 of these contacts became symptomatic. However, laboratory testing was negative for the SARS-CoV-2. Please note these contacts underwent a single test. Therefore, detailed interpretation of these findings is limited. Additional contacts that were not symptomatic were also negative for SARS-CoV-2. Illinois acute care hospitals were also monitored. There were no contacts that presented for care to the emergency departments in the area where these patients were sick. Okay, that's it. I encourage you to read more about COVID-19. This is very important for our future handling of these new cases.